Okay, we'll make a start then. Just want to thank everyone today for joining the Teams meeting. My name is Shazad Ali. I'm a clinical lead within the Digital Medicines Program within NHS England. Stepping in for Amna today, who's giving a presentation elsewhere. So again, just thank you to everyone for making the time. I'm sure most of you, if not all of you, are aware the ePrescribing Masterclass is an opportunity for people to present the great work they're doing across the country, help share innovations or help to learn from best practice and share that insight, but also to network as well amongst one another. So we're really fortunate today to have three really insightful and unique presentations. So the first one is the impact of introducing electronic prescribing. So a number of us have obviously gone through that whole journey of moving from paper onto electronic systems. So this is the first presentation is around the risks involved in that, especially from an anticoagulant prescribing perspective, and how a multidisciplinary team was able to find solutions to that. So thank you to Joe, Kelly, and to Katie Allen for joining us today. The second presentation is around closed loop medicines at Liverpool Heart and Chest. And again, a number of places across the country have started to use barcode medication administration. So again, this is useful for people to understand what the challenges are, what benefits are, etc. And then the final presentation is from Anne, as I'm sure many of you are familiar with Anne's work. And this is on the ePrescribing work. So again, this is helping to ensure the systems are used appropriately and safely and to benchmark them against one another as well. Okay. So Joe, I'm just going to give a brief introduction to Katie and Joe. So Katie Allen is the Electronic Prescribing Medicines Administration Principal Pharmacist at Maidstone and Tunbridge Wells NHS Trust in 2019. She led the design and development of Sunrise EPMA prior to the rollout in 2022 and continues to optimize the system in collaboration with both frontline and patient safety teams. More recently, she's worked closely with business intelligence to develop a digital medicines dashboard so that medicines-related data can be more easily derived to further drive quality and improvement. She's also contributed towards other digital medicine solutions, including iPro Surgical Care, which is integrated with Sunrise and works closely with the wider EPR team in order to streamline crossover processes, for example, VTE risk assessment and antimicrobial review. Joanna Kelly is the Chief Nursing Information Officer at Maidstone and Tunbridge Wells, a role she's held for the past 3 years. During the tenure, Jo has played a pivotal role in driving the organization's digital transformation strategy, overseeing and supporting key initiatives such as the implementation of electronic prescribing and optimization of the EPR, the deployment of anesthesia software solutions, and the introduction of robotic processing and clinical automation tools. That includes automated vital sign monitoring. There's been a strong focus on clinical engagement, and Jo ensures that all digital solutions are selected and implemented in close collaboration with frontline teams, aligning the innovation with the real world-class clinical needs in order to deliver the safe, more efficient patient care. All right, so I'll hand over to Katie and Jo. Thank you very much for joining. Thanks.
Thank you. Thank you for having us today. So we are going to, as it says on the slide, talk about the impact of anticoagulation management when introducing a new digital system, and sort of understanding, identifying the challenges and new risks associated with bringing in an EPMA, and what the multi-professional approach that we took to address some of them. We haven't fixed them all yet. Next slide, please. So we are from Maidstone and Tunbridge Wells. We have roughly 700 beds. We're quite an acute trust in Kent, about 8,000 staff. We introduced the EPR system, Altera Sunrise, back in 6 years ago, I want to say, and then waited a little bit before implementing EPMA, which is 2.5 years now. Katie's nodding because I got that wrong yesterday. When we deployed the system, we were quite in our infancy. We obviously had an EPR out there, but I think it was a big cultural change for the trust to bring in an electronic prescribing system from completely from paper. We as every trust does, and I think every trust has been through this, we look at the benefits, we looked at the risks, and we really felt that this was going to take us on the next important, exciting journey to sort of eradicate a lot of those risks and bring in new benefits to the trust. We have a very multi-professional collaboration approach, and something that has been definitely defined and refined over the last sort of 6 months to a year, and due to these sort of reoccurrent risks that we didn't think that we were going to have, we are going to just focus on anticoagulation, because I think that's something that generally is a problem as a management as case study, but we obviously have looked at lots of different areas generally with risks. Next slide, please.
So first of all, we just wanted to sort of have a look at how some of the risks have changed since the introduction of EPMA as a more generally than simply anticoagulation itself. And we started by looking back at some of the anticipated benefits of EPMA and comparing those to the lived experience of what people have, our frontline users have come back to us to tell us how EPMA has improved or hasn't improved. And I think that we've sort of come to realise that the benefits that we thought we were going to achieve once EPMA was implemented has been more of a gradual process as the system matures over time. So some of the benefits, some of the safety benefits were experienced straight away. So as soon as EPMA was implemented, so for example, real-time access. So as soon as EPMA was rolled out, we never had the lost drug charts anymore. Worklist Manager could be viewed by multiple people at the same time. Drug charts could be remotely reviewed and monitored, for example. And then some of the benefits we've started to see, but we haven't, I don't think, fully realised that benefit yet. So an example of that is in improving our prescribing. So we have a drug catalogue, so we don't get any misprescribed medicines anymore. We've got a series of order sets which are developing, which we can use to streamline prescribing. So, for example, an anticipatory medicine order set. And we've also used order sets to help with cost-saving switch prompts. And then some of the perceived benefits, some of the benefits we were expecting to see, we actually haven't realised those yet. And in fact, sometimes they've actually introduced risk or an additional risk. So, for example, clinical decision support. We thought this was going to, help with, I don't know, interactions, allergy, for example. But actually, what we find is, although we've limited it to only the most severe interactions, actually we've got too many of these alerts, and our clinicians are telling us that they experience alert fatigue if effectively they don't see these alerts and simply click past them. So I suppose it's a gradual accumulation process. I do think that some of these benefits that I've said we haven't seen yet will be benefits over time, but it's a sort of process that we need to work through. Next slide, please. And so, thinking more about anticoagulation specifically, we experienced an increased number of patient safety incidents when I think that's probably fair to say, once EPMA went live. And through looking at these incidents, we've very broadly sort of arranged them into 3 up to 4 sort of distinct categories. So the top one is around the view of information. So the processes are actually much more separate now than they used to be. So on a paper drug chart, for example, that VT risk assessment was very prominent. It was on our drug chart. It was on the second page. The VTE prescription was straight underneath it. So as soon as you open that drug chart, you could immediately see whether VTE, the risk assessment, has been completed and the co-prescription had been prescribed or not. Whereas now our VTE risk assessment is within a document that, once that document's been completed, it's sort of, falls down the list, and so resurfacing that information is quite difficult. In addition to that, the administration view is different. So we're finding that in order to streamline processes, our nurses are changing the work list manager view to simply just look at tasks due now, instead of taking into account medicines that might have been given at another time. I've already discussed alert fatigue, but this didn't happen with paper. And actually, we've managed to pull some data to say that 25% of all of our medication orders have an associated alert that flags up at the point of placing that order. So yeah, it's very, very frequent. There's a lack of visual prompts for completing documentation. So I think I sort of spoke about this previously. So before, on paper, you would see the risk assessment as soon as you opened up the drug chart, whereas now it's not as prominent for people to complete. And then the last thing was, again, our clinicians say they experience click fatigue. So multiple clicks are required to prescribe, whereas on paper, it was simply much easier to handwrite a prescription. And certainly with VTE prophylaxis specifically, once the risk assessment is completed, at the moment it's an 11-click process, which is quite a lengthy process in order to prescribe deltaparin, for example. Next slide, please.
Thanks, Katie. And I think just to add to what Katie was saying, sort of give a bit of an example. I had what we tried to do was once we sort of identified that these risks were occurring, is actually get that out on the wards and talk to prescribers, talk to administrators, talk to the pharmacists, really try and understand what the blockers were, what the challenges were. And one of the things that we found is that there's duplicate prescribing when they don't want duplicate prescribing. So say 2 prophylactic anticoagulants are prescribed, and sort of me pushing back saying to the doctor, why did that occur? And they said, well, the system let me. I don't think the system should let me. And me saying, well, actually, it does come up with an alert. And they said, I didn't see that alert. And I think we do see this quite often where, I know it's a common knowledge with alert fatigue, but actually they just don't even see that information in front of them. And they almost want it to stop them to have the ability to make those mistakes. And I think another risk is that we almost, by having that clinical decision support, we're almost taking away some of those clinical decisions that would have been made so naturally previously on paper. You would have had to think through those processes. You would have had that patient in front of you. Sometimes when you've got that guidance to take you through a process, you almost sort of forget what that process looks like, and you sort of go into autopilot, and you miss things that way. So we tried to sort of gain as much information as possible out on the shop floor, and then we really wanted to take a multi-professional approach to try and to mitigate some of these. So myself and the CCIO were involved, and our deputy medical director and our deputy chief nurse were both involved as well, and they look after the quality and safety side of things. We had consultants in the field. We had we obviously had Katie, we had our VTE nurse, patient safety lead. We had further pharmacists who were actually out there supporting and looking at these EPMA drug charts on a day-to-day basis. And then importantly as well, I think for us, we had the people who could sort of make these changes and fix these issues. So we had business change support and configuration support as well, which it was vital in really trying to understand what we can do with the system to obviously support some of these mitigations. And I think we try to take an approach of we just don't we don't want to just put a fix in or put a plaster over it. We need to look at that whole process from the beginning. Are we doing this for doing its sake, or are there things that we can actually change the process and adapt into this electronic world? I think time and time again we see that you go electronic, as in you move from a piece of paper straight into the electronic system. You don't change to that digital approach. Next slide, please.
So one of the ways that we have tried to mitigate the risk for the fact that there's a lack of visual prompt to complete the VTE risk assessment is to introduce a mandatory, introduce a hard stop. So we're fairly generous, I think. We allow 12 hours to pass, and if the VT risk assessment hasn't been completed after that time, then there's a hard stop to prescribing any further medicines. And that has actually worked to increase our VT risk assessment to 98%, which we're very pleased with. Next slide, please.
Sorry, I couldn't find my mute button. The other thing we've done to sort of mitigate the fact that everything's in so many different places is to try and create a clinical summary view. This doesn't just show VT risk assessment and the anticoagulation prescription. It also shows fluid balance, news, a summary of what they've come in with, etc. And the idea is it pulls all the core information from lots of different documents and lots of different places within the EPR, and it gives a real-time overview summary of that patient's care. So hopefully, we're hoping as this goes live, that this will improve that visibility and oversight for those doctors before they prescribe. They've got that again, or before they change a prescription, they've got that information there, and they can see if the assessment's been complete, etc., and what the status is.
Next slide, please.
Next slide, please. Sorry.
Just got 1 minute left, guys, just to let you know.
Okay, I'll try and whiz through these. The third thing that we haven't introduced yet, but we're in the process of developing is I can never quite remember how to sort of word this. It's like an admission order. So obviously there are a cohort of patients who shouldn't have VT risk assessment, shouldn't have VT prophylaxis prescribed for various reasons. So for example, maybe they've got a bleed and it isn't appropriate. And so to increase clarity behind that decision making, instead of just not having VT prophylaxis prescribed, we are developing an information order to sit on our worklist manager to say that the decision is that it shouldn't be prescribed, and that will also feed through to the clinical summary view that Joe just shared. Next slide, please. And the final thing that we're hoping to do is to simplify the prescribing process. So like I said earlier, at the moment, it's an 11-click process, and we think we can drop that down to 4. The reason why it's 11 clicks at the moment is because there's almost a lot of clinical decision support built into the order sets, but feedback from our prescribers is that they don't necessarily need that. So therefore, we can simplify that prescription. Next slide, please.
Thank you. So yeah, in conclusion, you can see there. So I think it definitely opened our eyes up to the fact that yes, we are introducing this great system. We need to move forward, but the fact that it can also introduce unique new risks associated with sort of digital medicines. I don't think sort of the general staff would have even thought about these things at the beginning, and I completely understand that. Obviously that's why we have clinical safety officers and things to understand this, but you don't know what you don't know, and I think that was really clear when we sort of started our journey. The management of it is high on our list. And it's something that will be ever reviewed, and this will be an agile piece of work for us to have a look at. We really wanted to do this in a staged approach as well, because actually if we put all these fixes in one go, we will never know what it is that sort of made the difference and if there was improvements. So we've done this in really a staged approach to learn from what went well, what didn't, and then move on to the next one, so we can really understand what improvements were made. And having the multi-professional approach has been fantastic, and we've now adopted that for all sort of these mini projects almost, or work streams going forward. Thank you.
Thank you very much, Katie and Joe, for a really, really impressive presentation. It's great to see the work that you've done in innovation as well. I was going to say it's great to see that multidisciplinary team approach, which you have taken with all the different professions. There are a number of questions in the chat, and I think you guys kind of demonstrated how you've been working with other team members as multidisciplinary team members, but you've also got multidisciplinary talent yourselves. So you've been, whether it's clinical safety officer, whether it's answering questions on the fly as well. Well done, you guys. So that's it's really good. So yeah, I just want to say thank you very much. And if anyone else thinks of any other questions, feel free to drop them in the chat with Katie and Joe, and hopefully we'll have some time at the end as well. But yeah, if we just move on to the next speaker who we're fortunate to have. So we've got, I believe we've got from Liverpool, we've got Graham Holland, who's the Deputy Chief Pharmacist at Liverpool Heart and Chest Hospital, and is digital lead for pharmacy. It's 200-bedded tertiary centre for cardiothoracic surgery, cardiology, respiratory medicine, and adult cystic fibrosis in the northwest of England. Highly digitally advanced organisation. They've had an EPR since 2023. Achieved HIMSS level 7 accreditation in 2024, which is phenomenal, and compliant with closed loop meds as well. Currently engaged in the first type project with NHS England to bring IVs and CDs into the scope, closed loop medication as well. Graham, thanks again for joining us and for presenting. It's much appreciated. I'll hand over to you.
Thank you very much. Good afternoon, everybody. Well, there's lots of information to go through. I'll try and rattle through it as quickly and accurately as I can. If I could have my next slide, please. So just to start on what is closed loop medicines, there's two aspects in the approach that we took: closed loop medicines administration and closed loop medicines supply. So if we start at the top of the left-hand side sort of loop, in our system, you select your patient, you access their electronic prescription. This brings up the medicines that the patient is due at that time or within a defined window. You scan the barcode on the patient's wristband to make sure that you're in the right patient's profile. That brings up that confirms that you're in the right patient. At that point, you either have the medicines that the patient is prescribed, or you don't. If you don't, then you go into the other loop. So a pharmacy medication request is sent via our EPR system to our pharmacy. It's reviewed and signed off by a pharmacist. A supply request is submitted, and that crosses an interface between our prescribing system and our pharmacy stock control system. It's issued via a robot, delivered to the ward for the nurse to give, and then you re-enter the closed loop medicines administration loop. Obviously, if you have the medicines on the ward, you don't need to use that yellow loop. You scan the medicine. If you have bisoprolol 2.5 and the patient's due a 5, then you scan twice. If you scan something that the patient isn't prescribed, so you scan aspirin instead of amisulpride or the other way around, it says that it's not matched. You go through that list, make sure that everything is matched, and then click for administration. An electronic signature is pulled across onto the drug chart, and you move on to your next patient. I'd have my next slide, please. Why is this important? Well, the medicines administration bit in particular, obviously, most errors occur at the administration stage because medicines are prescribed once, they're dispensed once, but administered multiple times. So the closed loop medicines administration section sits in between the multiple risk-taking opportunities of administration process and the patient to improve patient care. If I could have my next slide, please. Bit of a timeline here at the Heart and Chest. So we use, similar to Katie and Joe previously, we use Altera's Sunrise EPR product. We have had that since 2013. We were HIMSS level 5 in 2019, and we've been on a pathway to HIMSS level 7, which we got last year. lots of words on that slide, but that's the general trajectory that we've been on. If we could move on to my next slide, please. A bit about how we actually did it. It relies obviously on mapping a manufacturer's barcode to product in your EPR drug dictionary. The challenge is there are multiple. Every manufacturer of the same product uses their own barcode. New products are brought to market. Old barcodes aren't necessarily archived appropriately. Some products carry a barcode on the outer packaging, such as creams and lotions and potions and eye drops, but not on the final product that the nurses actually got their hands on to use. And nobody carries a complete and exhaustive catalogue of these products and barcodes. So you have to code it all. So we have, at the last count, we have 18 barcodes associated to aspirin 75 milligram dispersible tablets and 17 barcodes associated with the enteric coated or gastro-resistant preparation. So you can see that the amount of configuration is vast and it changes all the time. So we are a number of years post go live with this now, and we're still adding 20 to 30 barcodes to our system every week with new products, things that we haven't seen before, things that are new to market, or barcodes that used to be used for something else but have now changed. If I could have my next slide, please. Katie and Joe mentioned multidisciplinary working. That was a huge piece for us. We had a project board with lots of stakeholders from a wide range of disciplines. We met regularly to design the project. So the senior nurse leads championed the project as a patient safety initiative. We didn't drive this as a technical or a digital or a pharmacy project. This was a patient safety project. Our education department trained hundreds of nurses. The project managers supported us on go live with floor walking support. Our IT team created a fast track hardware resolution hotline for scanners, laptops, computers on wheels, all those things that go wrong and can be potential barriers to compliance. The EPR team configured the system to accept thousands of barcodes across our entire EPR drug dictionary. We did in pharmacy, did a lot of the testing and quality assurance. And then, of course, our front-end users accepted a really complex change process really well, actually, and I'll come on to a bit about compliance in a second. Could I have my next slide, please? So how did we go live? So we had multimodal training, lots of options there, delivered by lots of different people, tried to catch as many as we could, people who only work nights, people who only work weekends, people who have different learning styles. Nurses tend to be sort of active learners, so doing things on the job. So we tried to do a bit of that with board-based demos and play and learn environments. We had an incremental rollout across the organisation to make sure that everyone had reached a certain training threshold. As I mentioned before, our IT team came up with a fast track hardware failure pathway. We designed BAU processes for capturing new barcodes and generated scan compliance reports so that we could ensure that there was good oversight of the new process. And what did all that sort of result in? We move on to my next slide. There's a bit about benefits realization. So we can see our trust compliance, which was very good and continued to rise, and is still really good. On the right hand side is our reported medication administration incidents. So you can see when we went live, there was a big drop, and it sort of continued to drop as people got used to the system, used it better, and we configured it to how patients actually use it. You'll see that it's not zero. The reason part of the reason for that is that not everything is in scope of closed loop. So as Shazad mentioned at the top of the presentation, we are involved in a first of type project between ourselves and our supplier and NHS England to create the functionality within the system to do closed loop medicines, with the preparation of which is away from bedside, so IVs and controlled drugs. If we could move on to my next slide, please. There's a bit more benefits realization. So we looked at our dispensing errors. So they haven't changed a huge amount, which is disappointing. But what we have found is that because the interface between our prescribing system and dispensing system works so well, that actually the prescriptions that don't go through that interface, so paper-based prescriptions, controlled drugs, some of the SLAs that we look after, some of the outpatients that we look after, we're getting a disproportionate increase in the number of errors of them, because I think the interface is doing such a good job that it's de-skilling people. So we've introduced, closed off one risk and introduced another. So they're errors that leave the pharmacy department, but actually near misses, which is the right-hand screen, where you can see that there has been a big drop with the interface, with the number of near misses that are caught before they leave the department. Next slide, please. Lessons learned. Closed loop medicines is for life, not just for Christmas. You need to invest in people and skills and hardware. The go live is the start of the journey, not the end of it. So you need those people and skills to continue to develop the system as you correct mistakes that you've made in config or or shortfalls in training, etc., but also to add those barcodes and to respond to incidents as they occur. Teamwork, early stakeholder involvement is really, really important. We had a multidisciplinary project board, as I mentioned. Include your suppliers, because they want you to succeed with this. And collaborate. So we were the first in UK to do this with our system. We have since helped others to do likewise, and have that multidisciplinary and multimodal training offer. Technical, be creative with your config. So as I said, we had to do a lot of work around collecting barcodes post go live. So we've got various mechanisms for that. One of which was we have a no scan report which we run every day, and have a very clear escalation process to IT for hardware issues. And also remember why you're doing it. As I said, we drove this down a patient safety aspect rather than anything else. Very briefly, future plans. My final slide. Electronic ward stock orders, which we went live with a couple of weeks ago. We're going to support a newly founded Liverpool citywide group with their EPR procurement. We're hoping to bring IVs and CDs into scope within the next 6 months, hopefully this calendar year, certainly, and then in the future EPS, the same as everybody else in the world that's crying out for it. We want to move to tech supported stock picking of items stored outside of our robot, and we want to try and move to electronic controlled drug ordering. So whilst we are a very digitally mature organization, there's still loads to do. And I think that's me. Hopefully I've just about stuck to time. Sorry if I rattled through it a bit quickly. Happy to take questions at the end or in the chat, or reach out to me. Thank you.
Thanks, Graham. That's some phenomenal work that you guys have been doing over Liverpool Heart and Chest. I mean, to be the first in the country to use a system with closed loop medication administrations is really, really amazing work. And it's innovative as well. A lot of the stuff that you've done, so that's been brilliant to hear. And there's a flurry of questions in the chat, so feel free to have a look, or we can just wait until the end. If we have time, we can go through them as well. But again, just wanted to convey our thanks for that. And yeah, I like the phrase. It's closed loop is not just for Christmas; it's meant things thereafter as well. Absolutely. Okay, so we'll just move on to our next presentation. Okay, so for the next presentation, it's about the ePrescribing work. Ansley, I'm sure many of you are aware, has been leading us work for a number of times, particularly baby. And question was, how do I think Amna spoke to Anne and said, how do you want Shazad to introduce you? And Anne replied, yeah, Shazad knows me and that'll be fine. There's no introduction needed. But I think that's probably the case for the most of us. But I'm just going to give a couple of brief highlights. So many people are aware of who Anne is and the wealth of expertise and knowledge she has. And she was a previous senior responsible officer for overseeing ePrescribing nationally. She was one of the sole voices years ago when we were in a paper to electronic systems situation, and she was banging the drum, by herself a lot of times. And She did a phenomenal piece of work with the ePrescribing implementation guidance. I'm sure a lot of people of you guys have seen it. If you haven't, it's one of the first to actually have the unique foresight to look at different perspectives from a managerial, implementation, or implementation perspective as well. And the nice thing is as well, she always ensured people always get connected to one another to share best practice. So I remember going to one of the days we had organized, like one of the big group days, and they had one of the agenda items was speed dating, and my wife saw that and she was like, Shazad, what the heck is this? And I had to explain to her that she's actually just trying to connect all different people whilst my wife was calming down during that point. So anyway, no further ado, Anna, over to you.
Thanks, Shazad. I'd forgotten all about speed dating.
Yeah, I hadn't. That was a very stressful day of my time.
Next slide, please. Thanks for the invite. I'm here today to represent the ePraise team. ePraise stands for Electronic Prescribing and Safety Evaluation. We now have some results from the work that's gone on in this last 12 months, and it's my privilege to chair the board. Next slide, please. So what is ePraise? Just as a reminder, it's a tool which is available for yourselves to actually assess how well your individual configuration of your electronic prescribing system is mitigating known medication risks. We've had a couple of presentations already which have identified some of those high-risk areas that you would want to look at if you're actually thinking about how you optimize and move forward with really creating maximum benefits from your system. You know, Katie and Joe really outlined one of the areas around anticoagulants, and the presentation from Liverpool showed us that, you know, focusing on administration again is an area that is worth thinking about. So ePraise is a tool for you to use to help you understand whether the approach that you're taking to actually optimize your system is working when it comes to understanding how well you mitigate known medication risks. There are now things happening for those that took part in it this year, which I'll talk about in a moment. Particularly, we've now pulled the results from this year, which will allow you to benchmark so you can see how well you compare nationally, but also with your peers using the same system. And off the back of this, we're now creating a learning lab, which will provide a toolkit, which will give you some more information as to how or where to focus on optimization. And there'll be some case studies in there from sites that have done particularly well, or as per the two presentations we've had, have really focused on areas and are moving forward with showing improvements. Next slide, please. So what I'm going to do is run through very quickly some of the headline results from this last round of tests. I think it's fair to say that there is a lot of opportunity to improve the safety and performance of very many of the systems that are out there at the moment. And by systems, I mean individual organisations. I don't mean EPMA systems. Whilst there might be some improvements for individual system suppliers, largely what we're seeing is it's actually about the configuration at a local level rather than the actual system itself. And again, I think Katie and Joe absolutely identified that by talking about how they were revisiting how they'd set their system up to see if they could improve and address some of the challenges that they were hearing back from users. Those people that took part this year will be getting an email in the next day or so, giving them a link to help them further explore the data that's available, telling them which trusts they are in the anonymized list so they can have a look and see how well they perform against others. Next slide, please. So for the results this year, there were 71 organisations that completed the assessment, 47 acute, 1 community and 23 mental health trusts. And for the first time this year, we included a lot of mental health questions. And thank you to the clinical group that helped pull the questions together for that. We have a good geographical spread, north, south, east, and not quite west, but maybe Wales will join next year as they go live. Next slide, please. There was a good spread of all the systems that were being used. So there were 17 different vendor systems tested. The slight outlier is the intensive care system that somebody was using, but the reality is that very many of the tests are equally applicable to that as well. Next slide, please. So if you remember, what we're looking at here is how well you mitigate, or how well we expect the systems to mitigate against individual tests that we provide you with. And you can see that the good mitigation scores are hugely variable across the trusts that responded and completed the test. So there's wide variation across both the individual organisations, but also within the particular type of electronic prescribing system. Next slide, please. If you look at the same slide with the green lines highlighted, the green lines are all from exactly the same system supplier. So you can see that there are those who are using the same system that have scored incredibly well, but there are those using the system who've scored very poorly. And it is not to do with the system version that they're using, because we collected information about that this year. It is to do with the way that you've actually configured and set the system up, or where your focus has been when you've actually configured the system. The focus may well have been away from some of the challenges associated with medication safety and risk. And what we're suggesting is that for those trusts who've performed less well than they might have expected, please learn from others within the same user group, shall we say, because you can share this now between you, but also think about the approach that you've taken. You know where the high risk medicines are, or you know what the high risk medicines are. So think about, as we've heard with Maidstone, you know, are you looking at are you doing particularly well with your anticoagulation prescribing, for example? So think about the approach that you're taking. Think about where we know high risk issues will be with medicines, and you will be spot on when you come to do this again next year. Next slide, please. If you look across all the systems, so you look at the average mitigation score across all the systems, you can see that there are some that do slightly better than others, but when you average them out, there's room for improvement in all of them. And the highest score that we got, as you saw before, for good mitigation was around 80%. So even the best has got room for improvement. What you can see for this is something, again, that we've heard already today, is that sometimes that good mitigation comes at the expense of over mitigation, shall we say. There are too many alerts firing. But you can see again that there are some sites that seem to have got the balance about right. But the area that worries me particularly is where we've got no mitigation for some of these areas, and they're the areas that I would suggest that we need to focus on for next time round. Next slide, please. We had 5 mandatory questions for all sites, and these are, I suppose, what you would describe as the never events for electronic prescribing systems. So the areas that we would expect all systems to be able to mitigate all risk, or at least as much risk as possible. They're the areas that you would instinctively know, I would hope. So no once daily methotrexate, for example, not being able to prescribe insulin in mils rather than units, and so on. Now, we did 5 tests last year. We've done 5 tests this year. 1 test we're excluding this year because your feedback to us tells us that we got the wording around the test very wrong. So the test around insulin glargine we're going to exclude. As you can see, it was poorly responded to, but it was because we screwed up. So thank you to all those people who told us in no uncertain terms we needed to improve. But if you look at the other areas, you can see, particularly, let's focus on the methotrexate for the moment. There are still systems out there that are allowing prescription of once daily methotrexate, which I would suggest is not good enough. If you move on to the next slide, please, you can see that it can be improved. You can see with the system on the right, particularly when you look at methotrexate, the majority of systems are managing to mitigate well, and some are managing some mitigation, but maybe not complete mitigation. So that suggests to me that there's some shared learning that could be made between those individual organisations to actually show how you could improve and manage to actually mitigate there. Next slide, please. When it comes to the actual type of category, so these are the types of tests that we're running, and the descriptions for or the definitions for these are actually available on the website. You can see where people did particularly well and where they did less well. And I think that provides us with an opportunity to actually think about where you might focus your efforts moving forward. Drug omission, for example, is very poorly managed, whereas drug duplication tends to be managed in a better way. So have a look at that when you get the information coming through. Have a look and see how you compare to the people using your system, see how you compare generally, and see what you can do in terms of thinking about your approach to those areas and where you might think that you are missing a trick in terms of managing the risk, particularly for medication safety. Next slide, please. We're missing a really good trick with lab integration with electronic prescribing systems, and yes, some systems will not allow this and yet haven't developed the functionality, but maybe now is the time to start pushing the system suppliers to do this. If you look at System 5, clearly one site has understood how they can manage this and do something to mitigate not having access to lab results as you're prescribing. The majority have not. What can you learn from each other? System 3, the majority are doing it, one is not. So what is it that's happening that will allow you to do that? And for those working with System 7, 6, 7, 8, maybe this is the time to get together and start to talk to your system supplier about how you actually move forward with bringing information in. Next slide, please. And one really simple one, which was highlighted by the medication safety team nationally. There are many errors occurring at the moment with penicillin and penicillin allergy being missed because people are misdescribing penicillin in their system. Penicillin and penicillamine, of course, can be very easily misselected. You should be describing penicillin V as phenoxymethylpenicillin, and that in and of itself reduces the risk of that misselection occurring. And you can see if you look at the system responses that we've got, there is a huge variation in how people are describing penicillin V, phenoxymethylpenicillin, etc., etc. DM&D has the definitive description as to how this should be described. If everybody does it the same way, our prescribers will start to learn and understand exactly the best way of doing this. While we continue to all do it slightly differently, we are more likely to perpetuate errors where penicillin and penicillamine continue to be misselected, and therefore opportunities to reduce error missed. Next slide, please. So where do we go from here? So there are sites who've absolutely understood the approach that we're trying to take here, and they're telling us that they've learned both from the assessment process itself and the results that they've seen. And they've gone back and they've revisited certain areas within the system, whether it's high-risk drugs, whether it's an approach to actually an area like allergy, or as we've heard this today from Maidstone around VTE assessment. We're taking some of the feedback that you've given us, and there will be some improvements for the next version of the tool, which is due to come out in the autumn this year. At the same time, there is now a piece of work called the Learning Lab, which is also looking at how we can help you to understand approaches and where to optimize systems and how people have moved forward with improving and mitigating errors. A huge piece of work has just been completed around a literature research. So at the very, very least, and this is only the beginning of the journey, there will be a lot of summaries of that literature available so you can learn from others. There's also going to be a paediatric module for this year coming up. So specifically around paediatric prescribing, if you're prescribing for kids, how well are you doing with your mitigation and your optimization in that area? And that work's just being completed at the moment. The tests are just being finalized, and thanks again to the clinical reference group that's been doing a phenomenal piece of work over the last few months to actually pull that forward. And the last slide, please. So again, thank you to everybody that's taken part. Thank you to the ePraise team for their sterling work with doing the work that they've done. I think in summary, there are still opportunities for everybody to improve how well your electronic prescribing systems are optimized to mitigate known medication error. The mandatory questions really worry me. You know, if you cannot get daily methotrexate right, for goodness sake, please, if you do nothing else, go back and look at that. There will be information for benchmarking available at ePraise.info. User emails will be going out over the next few days to identify for people which their site is, so you can see how you compare. And please stop asking us to share the questions. We're not going to do that. This is about how you approach and manage the approach to actually mitigating known medication risk, as exactly was described by the Maidstone presentation earlier on. Thank you to everybody for taking part. We welcome your feedback. If you've got ideas, particularly ideas around where we should focus questions, or where you'd like to share some of the learning in terms of how you've approached and improved and outcomes, then that would be great to hear. Otherwise, thank you again. And Ali, Shazad, I'll go back to you now.
Thanks, Anne. It's really great to see that how the ePraise tool is just gathering more momentum and just increasing the user groups as well, and just improving everyone's journey. I still remember a while ago when you mentioned, we talked about the leapfrog study and how a lot of system suppliers in the US hadn't been optimized in the manner in which they could have been, and that meant a lot of opportunities were potentially missed. And it's great to see that we're kind of doing that work and taking it another step further, and allowing people to actually not just network, but actually understand what the opportunities are. So as you said quite rightly earlier, the places where there's nothing that's available at the moment, then those people need to get together and have that discussion. But there are places where there are functionality capability available, that people actually just need to share that information and share that learning. So that's great. And there's a number of questions in the chat, but just one of them that I think I know you'll know the answer to this, and so do I already, but I just thought it's a good discussion point. So is there, I think Francis Accor from Imperial's asked, is there a way of using ePraise to see how safe our system is regarding anticoagulation prescribing?
So we haven't specifically pulled out individual medicines or medicines therapeutic groups, shall we say, apart from the ones that you see as the mandatory questions. But you and I both know that anticoagulants are high risk. So I guarantee that there will be questions in there that you've responded to. So at the moment, we can't tell you whether your anticoagulation prescribing is mitigating as well as we might hope. But maybe it is something we might think about. And thank you for that idea. We might think about maybe a mandatory question about anticoagulation this next year. Just to see. But the question is, what would we pick? What would people see as the most benefit? Is it therapeutic duplication? Is it dosing? There's a lot of different things that you can get wrong with anticoagulation. So if you've got particular ideas, Francis, then please let us know. We'd love to hear them. It's an opportunity. We do revise the questions every year. So we do move the goalposts. Very sorry, but we do.
Thanks, Dan. Yeah, and I agreed. I think it's about trust determining, and potentially maybe we can help centrally as well, determining what are the most high risk medications that you want to consider, and to have those conversations about that and agree. And like you said, those need to change, to be honest. I don't think you need to apologize, because that way it's not, people aren't just tailoring this just for that particular question. They're tailoring the safety, and that's the outcome we want. So hence, not knowing the questions will ensure that happens. So yeah, definitely agree with that.
And Shazad, there's a clinical reference group which is responsible for looking at and does all the hard work behind the scenes with Stephanie and Ellie and team to actually identify where the focus should be, which tests come in and so on. So if there are people who feel very strongly about this and would like to be considered to join that clinical reference group, we'd love to have you, because the more learning and breadth in there, the better, because that helps us get the tests right every year.
Thanks, Anne. Yeah, and I think big thanks to Stephanie as well. Like you said, she's been in the background answering some of the questions as well. I think Craig asked a question about the trust took part, so Stephanie's answered that, so thank you very much. Just conscious of some of the other questions that are in there as well. So I'm just going to go to Louisa Conlon's question. If that's right, Graham, you still around? And Katie, Joe, if you want to answer, you come in as well. If you've got any thoughts, happy to have your thoughts as well on this. Yes, Graham, I think Louisa, I think you've answered in the question in the chat, so well done for multitasking. But I think it'd just be really, really useful for other people to understand this as well, who haven't maybe been involved in the closed loop medication administration side. Her question was, can you identify the number of full-time equivalents required, apart from business as usual, MDT support, and duration they're required to set up closed loop medication administration for go live?
Yeah, so for pharmacy, it was 3 whole-time equivalents. We submitted a business case for Band 2 ATO, Band 6 senior technician, and a Band 8A pharmacist. They sort of did a lot of the configuration and designing new workflows, etc. But we were on a pathway for improvement for HIM 7. There was beyond closed loop medicines administration, we did the interface piece with our pharmacy stock control system, which required a lot of config and testing and rebuilding of our drug dictionary from VTM to VMP or the other way around, and decisions around that and risk mitigation versus operational considerations. So we also, as I mentioned in the presentation, there's a continual optimization piece. We've had our EPR system for 12 years now, and it's been under constant evolutionary pressure as the needs change of the patients, of the system, of the pressures. So we were in a really fortunate position to have a business case approved where we were actually able to make those 3 whole-time equivalents substantive from original fixed-term contracts. So we still have those staff. They're still very busy. They're still driving a lot of the innovation that we want to achieve, as I mentioned, going forwards into the next couple of years.
Thanks, Graham. So how long did it take you to implement the first phase of the CLMA? And how long was the time span? And was that across the board, across the whole hospital?
It was about 12, I would say about 12 months. That was IV, no, it wasn't IVs, it was orals and NEBs, because at the time you needed 65% of your drug dictionary to go through closed loop medicines for HIMSS level 6. I think that might have changed now. And orals and NEBs just cleared that threshold for us. That's why we did that. It probably took us about 12 months, and with an incremental rollout over a period of probably a couple of months.
Thanks for that. And did you want to say anything about that? Or okay, that's fine. All right, then with that, I just want to say thank you very much to everyone who presented today. So Katie, Joanna, Graham, and the rest of the teams behind Stephanie as well. It's just all the other people I probably haven't mentioned. Big thanks to Sarah and the team for helping to organize this once again. And just to let everyone know that like all Netflix and Amazon Prime and all of the suppliers, but this will be recorded, so you can actually look at this again if you choose to as well. And the next masterclass is on the 21st of May from 1 till 2, and again be held on Teams. So scan to register. And if anyone has anything they want to share or would like to see, feel free to get in touch, or is open to suggestions people present, and ultimately here to help everyone network and share good best practice as well. Thank you very much. Cheers.